Welcome to Mission Report with Chris Dush. With 5 of the 7 counties I serve being declared maternity healthcare deserts, and having lost the Lock Haven Hospital and having 2 more barely hanging on, preserving and expanding rural healthcare access is of paramount importance to me. Every life, whether that's in rural Pennsylvania or in the city, they matter. And fixing what's broken in rural healthcare and addressing this man-made crisis is not a Democrat or Republican issue. It's not a hospital system versus independent hospital issue. It's a life and death issue. And we need to start treating it as such by coming together unified in order to help fix it. Joining me today is somebody who's been in the midst of that and working with everybody that she can pull together in order to help make that happen. Janice Walters is the executive director of the nonprofit Rural Health Redesign Center, who has become a close personal ally in our successful efforts to sustain vital rural healthcare services at Bucktail Medical Center, located in Renovo in Clinton County. And was it established in 2020 or 19?
2020.
2020. Yeah, the Rural Health Redesign Center offers a wide range of innovative programs and services to promote healthier communities, which include technical assistance, strategic planning, financial analysis, and emergency support for distressed hospitals. I want to welcome you, Janice. It's an honor to have you on today's Mission Report podcast. And if you would please, I'd like you to give a little more insight on your professional background and your specific expertise with the Pennsylvania Rural Health Model.
Well, thank you, Senator, for the opportunity to be here. I certainly count it a privilege, and I'm humbled and honored to have been asked. Certainly preserving access to rural health care is a passion of mine, which is certainly informed by a lot of lived experience, both as a rural resident. I spent most of my days living in the southern tier of New York State, but most of my professional career in Potter County, Pennsylvania. My professional experience is actually pretty diverse. Healthcare is my third industry. I actually started my professional career in accounting. I'm a cost accountant by training. And then spent some time in the communications industry with Adelphia Communications back in the day. And really fell into healthcare when I lost my job there because of, the demise of Adelphia and it being sold off to Time Warner and Comcast. And I had the opportunity to actually go with Time Warner. I had 2 job offers, but that would have taken me out of the rural community where I was born and raised, and my children were young and I wanted them to know their grandparents. So I actually said no to continuing with Time Warner. And I didn't know what my work was going to be. But a former colleague had went to the hospital there, Cole Memorial, and he called me and he's like, do you still want to come to Coudersport to work? And I like to say it was not a complicated decision, because in rural America, your phone does not ring every day offering you a job.
Yes.
And so when I got that job offer, it was simply like, what's the job and how much does it pay? And even that was a pretty simple math equation. Will the salary cover my bills? And the answer was yes. And so I like to say that was my glamorous path into healthcare. Really started just doing data and decision support. But then within a pretty short amount of time was asked to join the leadership team there at Cole Memorial in Potter County. So, specific to the Pennsylvania Rural Health Model, I became associated with that when I was the CFO there at Cole Memorial. I had come into healthcare right before the Affordable Care Act had passed, so in 2007, 2008. I have a lot of experience with the healthcare system. My husband has a lot of health conditions, and so we've been, I would say, avid consumers of healthcare. But when I came in, I could just see some of the fundamental things were really grossly broken, quite frankly, in the healthcare system. And so when the Pennsylvania Rural Health Model came along, I was considering joining that as a participant hospital and trying something different to see if we could produce a better path forward for the hospital. But then as circumstances would have it, a lot of personal, professional circumstances took me out of the community. And then I was asked to lead it would I come and lead the Pennsylvania Rural Health Model. So I've been pretty much connected with the program since almost its inception. I began leading it in 2018 and was really involved with the recruitment of the hospitals to the program and then building out the methodology by which, we're testing to see if we fundamentally change how hospitals are paid. Can we produce a more sustainable path forward for them? So it's been instrumental, the 18 hospitals that we worked with and, the payer community, there's a lot of momentum, a lot of great lessons learned. And I'm pleased to say, as I stand here today, there's a lot of interest in preserving that program and moving it forward to continue to evolve. And I would say build the better mousetrap for rural healthcare.
Well, I'm a supporter of continuing it too. But before we go into the specifics on how that operates, I'd like you to go back to since you were there at the beginning of Obamacare, what were the changes? I mean, as the CFO, I'm sure you saw some significant changes in the way the billing was done, that sort of thing. But can you go from there into the actually what the rural health model actually is designed to do?
Sure. Yeah. So, I mean, with the Affordable Care Act, I mean, hospitals have always struggled with a level of uncompensated care. There's a lot of cost that goes into healthcare. Hospitals are required to offer financial assistance programs. Hospitals are required when somebody shows up because of EMTALA law. Hospitals have to treat when somebody, presents to the emergency room, whether you have, payment or not, which is the right thing to do. And so I think the premise of, the Affordable Care Act was really to do a couple of things. Hopefully expand coverage through the ACA, give folks access to health insurance that maybe didn't have access to health insurance through an employer. And then also really the big portion of that, and where I spent a lot of my time, was, the HITECH Act and all of the money that was put forth to try to implement electronic medical records with the thought of, if we can just connect the data, everything's going to be better and that's going to fix the issue. And I think what we've learned is, great in concept, but garbage in and garbage out. And if you don't have the right infrastructure by which to make investments, it doesn't really change the payment paradigm. So again, that's where I spent a lot of my time understanding, Medicaid in the state of PA was eventually expanded. So we did have more people coming, through Medicaid expansion, getting coverage that didn't have coverage before. And then obviously the HITECH and really trying to connect hospital records and make data more transferable and transportable across providers, thinking that would impact, total cost of care.
Well, can I touch on that for just a minute?
Sure.
From some of the doctors that I talked to, the increase in manpower that's required as a result of that, the computers were supposed to make life simpler.
Right.
But can you touch on that a little bit about how much it actually ended up costing rather than?
Yeah. I mean, I can't speak to the actual dollar values, but I can certainly talk to exactly the point that you're making. It was thought that EMRs were going to make providers more efficient, but it actually slowed them down because of all of the different data entry requirements and all of that. Throw on top of that ICD-10, some of the coding changed not too long after that. And so, they're really, and a lot of providers were coding their own records and all of that. And so there was just a resource drain where we thought it was going to make them more efficient. And actually the tool did the exact opposite. So then you were finding that you had to hire scribes in order to keep the providers efficient. You were hiring extra staff to come in the room to actually scribe. And really it took away, I would say, a lot of the direct provider time. Providers were spending more time documenting in the EMR than looking the patient in the eye and having a conversation with them. Yeah. So again, high level concepts. And I think this is, as policymakers, there's always going to be either good or bad unintended consequences. And so as we think about change, I think the concept made sense, but the actual implementation and then even the ability, having done EMR conversions and all of that, if you don't get the right data into the EMR, you're not going to get the right data out of the EMR. So again, garbage in, garbage out. So anyways, As it relates to the Pennsylvania Rural Health Model, what we're specifically trying to do, it's, hospitals are struggling, for financial sustainability. And in rural, I really do believe that it's a convergence of a number of issues that is really creating, I would say, the crisis in rural specifically. We've got, and again, I've lived this. So much of my opinion, Senator, is formed by lived experience in a rural community and what I've seen firsthand. So the community that I was born and raised in the southern tier of New York State is a fraction of what it used to be. Most all industry has left. It's pretty much a ghost town. The school can no longer graduate a class because there's just not enough people. But as I step back and think, well, why? It's like, well, I've watched the manufacturing plants close. Nothing's replaced them. I watched Adelphia deteriorate. Nothing's, replaced it. So it's the economic, I would say, status of a lot of rural communities is one dynamic. How healthcare is paid for is the other dynamic, because currently we're paid in a volume-based system. And so you need to have significant volumes of services in order to make, like I like to say, the math work. Business principles are pretty simple. Revenue has to exceed expenses. And, anytime revenue doesn't exceed expenses, you're going to be in a environment that's not sustainable. And so what we were trying to do in the Pennsylvania Rural Health Model is like, well, if we fundamentally change how hospitals are paid and no longer pay them based on volume, but pay them based on health outcomes that we want to see. If we fundamentally change how we pay hospitals, can we really achieve three things? One, make them more sustainable, more viable. The second objective is to improve the populations of the health of the people served by those hospitals. So improve population health and wellness outcomes, which in theory, long-term should curb the total cost of care over time. We're really spending for sick care right now. And if we actually started to pay for wellness and health and investment over the long term, we should be able to, curb that total cost of growth that we're currently seeing in the American healthcare system. So fundamentally, that's what we're trying to do. I'd like to say there's two pillars. We pay through a fixed payment or a budget in exchange for a transformation plan. Two equally important pillars that in order for a hospital to get the budget, they have to commit to transforming away from a volume-based delivery system and really move to one value, gauged on population health, wellness, all of that, quality of care versus quantity of care. So in a nutshell, that's what we're trying to do. Currently the current program, the initial program is coming to an end. And so we're trying to figure out lessons learned, what worked well, what didn't work so well, how do we make improvements to it to keep that initiative moving forward?
Yeah, in the legislature, we often find ourselves spending more time trying to undo the problems we've created than actually coming up with good solutions or good things that help take care of the people. I've heard you say that the rural health redesign process, you've come up with favorable data relating to reducing what's called avoidable utilization. It's a fancy term for saying providing the right care in the right setting. At the healthcare summit, we discussed a possibility of putting Q-cares pretty much adjacent to the emergency rooms, so that people who are coming in, they traditionally, especially in rural Pennsylvania, folks put off going into the doc until it is acute, but it's not necessarily an emergency. And there are different financial situations for an acute care center versus an emergency room. You want to touch on a little bit of that and what you see as a way forward there?
Yeah, so I mean, my view might not be popular because I honestly believe we have to pay to ensure that access to emergency services stay in the community.
Yes.
And so if we're going to pay to ensure access to emergency care stays in the community, let's make sure that we're being efficient with the use of it. I think urgent care and some of these alternative solutions to emergency care are an effort to drive care to a lower cost of care setting. And so it all becomes about the cost. But as we think about the future, there's a role for urgent walk-in clinics to play, and there's a role for an emergency room visit to play. But as you start thinking about avoidable utilization, you know, some people will always have to show up at the emergency room. There's a lot of cultural things that need to change. We've got to change human behavior. So even though you make the urgent care available, does not mean the patient's going to use the urgent care. You can make, the urgent care available. But if a primary care doctor's office gets a call late in the day, it's not uncommon for them to say, hey, go to the emergency room instead of, hey, come in, because, people have lives and all of that. So there's a cultural dynamic to all of this. So certainly urgent care walk-ins, but I'm of the opinion, if we're going to sustain access to emergency services, how do we use those resources and use them really, really well, so that the patient that might need the emergency services gets the emergency services, but the person that, needs an aspirin can get the aspirin. And so how do we rethink the triage process? And we also have to think of EMTALA laws. There's EMTALA laws that dictate when somebody shows up at the hospital campus, what does that actually mean? Does that mean the emergency room front door? Does that mean that when they drive into, the driveway? So there's a lot of different, I think, things that need to be taken into consideration. And again, we want patients going to the right place. Yes. And getting the right care. But I personally and fundamentally believe if we get the payment paradigm right, the industry is going to respond.
Right. There's efficiency and then there's efficacy. I mean, whether it actually works or not.
Right. Yep.
You've been really helpful, and I want to thank you and your family as well as your team for showing up at Bucktail. The things that you did, your passion for rural healthcare just showed. Everybody that was involved with that project got to see that. And we were, with Representative Borowitz, the Clinton County Commissioners, the Senator Fetterman and Congressman Thompson. It was an all hands on deck experience, and it was nice to see. There was bipartisan support, but you were the key. You were the focal point to helping get things done. We had some changes with the administration that really helped, but then you went to work with the insurance providers, and I think that's a part of what your rural health plan is. Do you want to touch a little bit on how you worked with those insurance providers to help this? And then also, if you want to touch on some of the other things that we're doing up there to provide additional revenue streams. I appreciate it.
Yeah, sure. So yes, it's definitely labor of love. I am passionate about the work, the people. At the end of the day, all of these communities are just filled with really wonderful people. And I think at the end of the day, that's what motivates myself, my family, my team, is to really serve the people at the end of the day. As it relates to, it was a mess. Stepping in with the headline, hospital to close within a couple of days. And truly, the hospital is still open, Bucktail is still open today because of a community response. And so while, I might have been the one privileged enough to lead the effort, it wouldn't have happened without, I would say, a rallying of a lot of different community folks, including the payers and including other healthcare providers. So, things were so dire. I like to say I leveraged by every relationship that I had built to date to keep Bucktail open, calling a lot of the hospital leaders that I had, relationships with, saying, hey, I need your help. I had one leader personally stock her SUV with supplies from her hospital and drive them there to make sure the nursing home had what it needed. Within a couple of days, 𝐏𝐀'𝐬 sent a truckload of supplies that they donated. Because we inherited where, most of the suppliers, because of lack of payment, were not willing to ship supplies. So, as it relates to the payers, bills weren't getting out the door. The rev cycle was just not working. We quickly looked at the financial statements, and, one of the first things that I tried to do is figure out if the receivables that are on the books, is it truly a receivable? Is it truly cash that needs to come in the door, or was it, already paid and claims just not booked correctly? And so really worked directly with the plans outside of the rev cycle system. I mean, we took it and we were working with spreadsheets, just dumping information, meeting with the payers literally a couple of times a week to say, here's this claim. Can we get this one paid? Managing it very closely. And then really changing the payment. And again, I needed predictable payment. We needed predictable cash. So working with the plans to say, will you pay me differently? Like, don't pay me based on this widget. Just like, let's figure out a fair and reasonable compensation for the level of services, and will you pay that to me in a predictable fashion? And so, there were just multiple, the suppliers, nobody wants to close a rural hospital. I think that's the experience that I have here. Nobody wants to close an OB unit. Nobody wants to be, the supplier that calls, or the mortgage company that calls the mortgage that ultimately closes the facility. And so the other thing that we found, and again, we just picked up the phone and started calling people, because, there wasn't responsiveness. And so picking up vendors, or picking up the phone to call vendors and say, hey, we want to be a good partner. We see we owe you a lot of money. We see payments haven't been made for a while, but we want to be a good partner. Are you willing to work with us? Most of the vendors let us put together payment plans. And so we made commitments to make small payments periodically. And truly, I think everybody realized that if this hospital closes or goes back into the bankruptcy, they're going to get pennies on the dollar, and nobody wanted to see that happen. And so, basic communication, relationship building. And I will tell you, most of the vendors that I spoke to said, we're just thankful that somebody's calling us back, or somebody that
Yes.
you picked up the phone, So just that responsiveness, I think, moved us forward leaps and bounds. And then again, the payers coming to the table, really in the spirit of partnership. So again, it was a community a community effort is why Bucktail is still open today.
Well, you were the right person at the right place with the right background. I mean, your accounting background and your CFO experience. I think that you said about pouring through the spreadsheets, a lot of people would go cross-eyed doing that. And you were also, over and over again, I hear about your ability to make contacts with people and utilize the contacts from the hospitals, the other rural hospitals in Pennsylvania, the hospitals that you've partnered with, and you're getting good information from them that really helped inform you. And just to let folks know, we lost the hospital, except for the emergency room in Clinton County at Lock Haven, about a year before we were notified. And I only got basically about a day and a half notice. Everybody, it was very short notice. It almost happened the same way at Bucktail. And if we had lost Bucktail, it's over an hour drive for some people up there, having lost both of the hospitals in Clinton County, none in Cameron. And the hospitals in Potter, Clearfield Center, and Tioga, they're an hour drive away, and that's in good weather. I was telling people we're going to have to put helipads up all around the counties there. But I know we've been able to partner with some others, the Veterans Administration and others. We're looking at the possibility of bringing a veterans outpatient or clinic up there. What have you learned so far about those?
Nothing's ever as easy as you think it should be, or it will be. So there's lots of opportunities, but again, I think there's a lot of opportunity, but there, just transparently some physical plant issues that we're going to have to work through.
Yep.
Some connectivity issues. So I do think there's a lot of opportunity there. We've just got to figure out a couple more building blocks and pieces to layer in there. I do feel like, we've given the leadership and the board a pretty good strategic plan, some of which that, you've identified veterans and really using that space. There's good space there to be used for other healthcare type services, figuring out what that should be, really building out the primary care, I think telehealth opportunities, bringing specialty services in there through telehealth. I think that has a lot of promise. But again, there's just, so the technology issues, I think, is probably the most recent barrier that we're facing in terms of making some of this come to fruition. But there is a path forward. If we can keep good leadership, good governance, we do believe there's a path forward.
Okay. I want to go back to something I was talking about earlier at the beginning. There are 7 counties in Pennsylvania that are termed healthcare deserts. Healthcare desert, they're all connected. One of the guys up at the summit mentioned that desert implies it's something that's natural, and there's nothing natural about this. This is man-made, and I fully agree with it. But 5 of those 7 counties are in my district, and the other 2 border it. This is a real crisis. I know 𝐿 County here just a couple of weeks ago, they said that already this year they have had 6 babies born in ambulances so far this year. What do you see as the immediate and long-term things that we can do in order to start trying to correct this? Or are there any?
Well, I'm going to sound like a broken record, Senator. I truly believe if we get the payment right, and we ensure for maternity services in particular, if it's a service that we want provided, then it has to be sustainable. And so, part of the work that we're currently leading through the RHRC is next generation development of how do we ensure we've coined the term essential services. And what are these essential services, that need to be available? Where do we think they need to be available? I think the days of assuming every rural hospital is going to be able to deliver babies, given the demographics and the healthcare, the shortages. I mean, even just finding the providers, to deliver babies. But where does it make sense that whether it's, a hospital raising their hand to say, okay, I'm going to get back into the business, or if it's a birthing center or some other type of solution, we have to figure out how to pay for it and make sure it's sustainable, including, the professional costs, the doctors, the call coverage. We know in particular that, maternity in particular is very litigious. Malpractice insurance is crazy for that service line. So I really am hopeful, with the work coming out of our next generation strategy development. Maternity is one of those that we're focusing on. And I think the payers are at the table recognizing that it needs a solution. And again, I firmly believe if we get the payment right and folks know that the service is going to be covered, it's going to be sustainable, we're going to be able to solve this. But it really comes back to again, simple business equation. Reimbursement needs to cover the cost if we want providers to stay in the business of providing maternity services, or any service for that fact.
Well, I'm glad you brought up the litigious nature of Pennsylvania and the recent Supreme Court decision that allowed venue shopping to occur. When you're not delivering a whole lot of babies, you're not making a whole lot of money, and covering the malpractice insurance. They've Pennsylvania, the Supreme Court, which actually approved that, has actually upheld 2 settlements in the last year that are over $200 million. It used to be that stuff would get up to the Supreme Court and they'd toss it out and send them back and saying, hey, you've got to fix this. Granted, there was a problem here, but this is outrageous. And unfortunately, the Supreme Court and the law firms that are involved, it's not a good thing. We've had those law firms that are the biggest contributors have actually got signs up here in our area, and we're 5 hours from Philadelphia. So it's, and then when I'll make a point here too, when they've got a case that's not as strong, they'll take the docs down to Philadelphia for a deposition. They get down there, and then all of a sudden they say, oh, sorry, we got to be in court today. We can't do the deposition. We'll have to reschedule. Well, this doctor, he's losing his revenue for the day, plus having to pay for somebody else to fill in for him. So he's losing twice as much money.
Mm-hmm.
So it's a significant issue that's impacting us. And I'm glad you brought up about how that impacts whether a doctor wants to even come to rural Pennsylvania or any other state. You mentioned New York.
Certainly.
Any other rural area to practice. What do you see as the best lessons that you learned from your experience in talking with both your own background, the contacts you've made with all these other hospitals? That we've got independent hospitals as well as networked hospitals that are in rural Pennsylvania. And you've got a great relationship with all of them. And could you go into some of the lessons learned from all of this, the key points of what you think can be done? Again, I know I don't, you said about sounding like a broken record, but other than the
payment.
The payment, yes.
Yeah, no, I think what excites me about this work is everybody recognizes there's a really, really big problem, and we need to come up with a solution. And, you know, the state of Pennsylvania is unique. I think one of the, my lessons learned is, I do have the privilege of doing this work nationally, is a lot of states have not had the significant, I would say, acquisition of their rural hospitals by large systems. So there's a lot of states in the union that still have a lot of independent rural hospitals. But I think what I've recognized is, and I say this when I speak with, folks in the federal government, like our partners at the Federal Office of Rural Health Policy, it's whatever policy decisions that come out of DC cannot be about independence versus systems, because
Right.
The problems are the same. Our system-owned hospitals in the state of Pennsylvania are still struggling. We thought acquisition was going to be the solution. It isn't, because I have to say it, it's the broken payment, it's the demographics, it's the broader macro system issues that are creating the paradigm. And so I think that's a huge lesson learned for me. It's like, this can't be about system or independent. And even working with the plans and the payers as we think about a next generation solution, when we started this conversation back in late 2023, starting in 2024, the planning for next generation, it was very much, well, this should only be available for independent hospitals. And I really pushed back and I said, this has to be about the residents that live in these communities. This has to be about the people that live in rural Pennsylvania. Access to healthcare should not be dependent upon the name on the front of the hospital. And so whatever solutions we come up with, have to be ones that are palatable, that we feel are equitable, not necessarily about who, again, it's not system or independent, but preserving access to healthcare services. And so how do we define a program that we can all get behind, recognizing that at the end of the day, it's the people that live in the communities that need to be served, not system or independent hospitals or healthcare providers. So I think it's been a journey. I'm learning stuff every day. But I think that is one of the things that makes us unique is, we've tried the acquisition. It isn't producing a more viable. We're still losing OB. We're still, struggling with access. And so again, it's part of this broader macro system. But I do believe the starting point is preservation of what we have. It's like if we want to have an infrastructure by which to build on for the future, we have to preserve what we have. And whether, there's enough data and statistics out there that show if we want to do business development and we want to do economic development in rural communities, we need to have strong anchor institutions like healthcare and schools.
Yes.
To attract the young people back. So I'm not a hospital-centric healthcare person. All healthcare, it's a continuum. But in rural communities, hospitals are usually the backbone of the healthcare system. And so we've got to figure out a way to preserve that so that we have infrastructure by which to innovate for the future. And I also push hospital leaders when I'm dealing with them we shouldn't be thinking about rebuilding plant that looks like what we currently have, because healthcare in the 21st century is very different than what healthcare was in the 60s when a lot of these institutions were built. So how do we reinvent, how do we reimagine what the healthcare or the hospital of the 21st century needs to look like, given all of the technology and the advancements that we have? I would expect it to look different. And so pushing hospital leaders to reinvent themselves and be a part of that reinvention, or the system is going to, the system will make them become extinct if they don't start thinking of the future and taking this opportunity to rethink their own existence.
Well, and I think too, it was interesting. The Secretary of Health, the Secretary of Human Services were both at that summit, and I brought this up, and I've been saying it for several years. I think that what we were seeing in the rural part of Pennsylvania was eventually going to hit urban areas. And with the closure of 𝐄𝐩𝐢𝐻, that was it. That was a backbone of that community. 𝐄𝐩𝐢𝐻 Medical Center down in South Philly. Was the backbone of the medical community down there. Hundreds of jobs lost. And it was nice to see the secretaries coming up and actually listening. And as I said to them, there are so many waivers that our hospitals have to apply for because the regulations were written 40 years ago, and then it's simply addendums or whatever. And these hospitals and doctors and dentists, everybody's applying for waivers for different things. And I said, and a lot of times the two departments aren't talking to one another either. When you go into a hospital and they're saying, well, it depends on where or who's coming, where we put the fire extinguisher, because we get written up if it's here by one, and if it's and it's a lot of stuff that's like that. And they said that they were committed to rewriting the regulations, and I said, you guys need to start with the things that you're getting the most requests for waivers on, because that's where the biggest bang for the buck is. And we also need to have you guys talking to each other and coming out and dealing with hospitals and doctors' offices across the state, even from one county to another in the 7 that I serve. Center County, they've got 3 hospitals in the State College area, and I've got poor Bradford is about, or they're on the verge of losing their hospital. And they've just got a new hospital in State College. So even in the rural part of Pennsylvania, there are distinctions, and they're going to have to go in and talk to people all across the 67 counties so that when they're designing something, they design the regulations so that it can be, it can have the intent of what they're trying to do without creating a burden that stymies the ability for the doctors to spend the time that they need with their patients.
Absolutely.
So,
Absolutely. Yeah, I mean, and that's part of innovation. You know, one of the lessons learned, going back to the question that you asked me just a little bit ago of lessons learned, it's one of those things that as we think about innovating and, you know, framing for the future, a question that I like to ask rural hospital leaders or rural healthcare leaders is, what regulation needs to change? What regulations are stifling innovation? You'd be surprised how hard it is for healthcare leaders to actually envision a new paradigm because they're so steeped in the reality of their daily existence. Because it's a question that I've asked. It's like, if we're going to rewrite or redesign, reimagine rural healthcare, I firmly believe we have to do so through a lens of what do we want. I like to call it the white piece of paper exercise. Let's envision what we think it should be, and then layer into it the regulation that we think needs to be there to make it safe and effective. But what happens because of the election cycle, and you know, you all know this is like all of this takes a lot of time, and so what you end up have happening is piecemeal because we don't have the luxury of time to go back in or to step back and say, what should we have and how do we fit regulation for the future versus just trying to adapt and tweak what we already have to make it fit. And so I think that's why we find ourselves then in this waiver because we're trying to be innovative, but the regulation is actually stifling our ability to do that. And we have a hard time because we function in the reality of our day to day to actually even imagine what I could do if I didn't have this regulatory barrier or framework to work around. So again, it's been interesting to see how healthcare leaders respond when I say, what do we need? What flexibilities do we need? A lot of times I don't get a lot of meat back. It's not because they don't want to answer the question. It's they just have a hard time imagining a new paradigm without the regulation that they already have to live with. So the other lesson learned, we know it's needed. We know it's needed, but what exactly is needed is the hard thing to get to.
We clip these, and I'm going to kind of reverse it when we do. You know, in the Air Force Special Operations Command, it's thinking outside the box. Everything in the special ops, whether it's the Air Force and whichever branch, and even there, you've got people that have got blinders on because they're so heavily involved in their thing. Trying to get people to reimagine it.
Yeah.
That is something that I want to encourage the doctors, the hospital administrators to do exactly what you were just talking about. Take the time to get the blinders off and actually think of the things and get that information to you, because I know they can, if they take the time and do that, they can come up with solutions and ideas that you'll be able to put to use, and there'll be a benefit to hospitals and even the insurance companies and whatever, so that we can be more effectual and making sure that people get what they need. So
yeah,
that's a huge point.
Yeah, I actually experienced the same thing with the payer community. What flexibilities do you need when you're managing books of business on behalf of the Commonwealth or the federal government? What waiver or what regulatory flexibilities do you need in order to test something new? And I get the same response. They just, it's really, and I also like to say that's why innovation is so hard. It's because it takes a different mindset to think outside that box and be creative, to say, And that's why I truly do like to take people through a white piece of paper exercise and say, okay, we're starting with nothing. Tell me what the future rural healthcare system should look like. And I usually give people like 15 minutes in the room to just doodle. And it's amazing how some even struggle. Like some people are drawing pictures, but then there's other people that they just, if you don't have that gift, and truly we all have different gifts and we all have different
Yes.
talents. And so that's not a slam on anybody that can't. But not everybody has that ability to rethink and redesign as much as we would hope they could.
Yeah, bureaucracies exist, whether it's in local, state, or federal government or business.
Business, oh,
And
absolutely.
the larger the business, the more the bureaucracy, and it's so hard to get to people to think outside the box and take risks.
Mhm.
You know, yeah, sometimes we end up having to undo some things, but let's apply it on a smaller scale, see if it works, and
Right.
then start make it into a larger and larger system. I try to tell people the Lean and Six Sigma programs are great investments for corporations and for government to get people to start thinking outside the box a bit. And
Right.
I'd encourage anybody who has a business interest in hospitals and trying to get proper reimbursement so you can get the job done and take care of the local communities.
Yeah. Now I'm a big fan of Lean. I like to say I'm the annoying person that asks why 5 times because you got to get to the root cause. If you're going to fix a problem, let's make sure we're fixing the root cause and not just a symptom of it. And I truly do believe there's, if you ask why 5 times as it relates to the healthcare, what's creating, it goes back to larger macro system issues that we've just got to figure out how to stabilize so that we can start rebuilding and addressing root cause problems versus putting band-aids the symptoms. So
Yep. Well, I know one of the things that we're going to have to do too is solve some of the infrastructure problems that we have up here with broadband as well as roads, and getting rail back into the area so that we can get business interested in coming back. But one of the key things here is that if they're looking at hiring young people and we don't have maternity, then that's going to make it harder. And we've come to the point where there were so many of us who have been working to try and get the infrastructure needs taken care of in order to allow and get the regulations off the back of businesses so that we can grow. But if we can grow our communities, these things can end up being self-correcting if we give our healthcare providers the flexibility to do things that they know are effective.
absolutely. Absolutely. Yep, the stabilization, like I said, let's figure out how to stabilize so that we ensure we have a foundation to build upon. So
absolutely. We're pretty much towards the end of our time here. Do you have any last minute comments, suggestion on something that I haven't brought up yet?
Just that I actually think the future for rural healthcare is bright. There's a lot of controversy I know out there about the big beautiful bill and what's coming with that. But I think we have a bright future, and I truly hope that here in the Commonwealth that we're going to be able to put together a pretty powerful plan of how we can leverage some of that funding to really change the paradigm for rural healthcare in Pennsylvania. So I choose to be optimistic. I'm a blend between a realist and an optimist, and I lean more towards an optimist. But I'm hopeful that with all the energy and the focus that rural healthcare is getting in the state, that we have a bright future. It's going to be hard work, but we have a bright future.
I did see a House member get up, and a lot of the things that were being touted in opposition to it, he actually read all of the exemptions And it seems like the exemptions from the cuts were most of the talking points, which was interesting. And he was reading it right from the bill. So it's not going to be as dire as a lot of people are trying to make it sound. And quite honestly, I think with that 50 billion that's going to be divided up, it's going to help us buy the time that we need for you and others that are actively involved in this to help us come up with some solutions.
Well, yeah,
And
and that's right. Yeah, and that's
that gives me hope,
Yeah,
knowing that not only that the money's going to be there, the resources, but that you, all these other physicians and hospital administrators that are doing things right, that you're selective on who you have helping to advise you. I'm optimistic as well. So thank you for everything that you're doing.
You're welcome.
You've been a fantastic partner. And
You're welcome.
on
It's my
behalf of
calling in life, and until I'm relieved of that calling, I will continue to invest in rural health. So truly, I do, it is my passion, and I truly do see this as my calling. So there's no way I could have orchestrated my professional career that would have put me in this seat at this, point in time. So I will serve as long as I'm called upon to do the work.
Well, the hand of providence works wonders.
Yeah.
Thanks again, Janice. And folks, thank you for watching today's Mission Report podcast. And I want to, again, thank Janice and by extension, everybody on your team and all of the partners that have come alongside of her in helping to come up with some solutions to take care of our rural healthcare crisis. God bless, and stay vigilant, defend our Constitution, and have a blessed day.